Welcome to Beyond the Wheeze, the podcast where real stories meet expert insight on asthma and other chronic respiratory conditions. I'm your host, Josh Rayon, asthma advocate and patient voice. Each week, we explore the challenges, progress, and possibilities shaping respiratory care. Through conversations with patients, clinicians, and changemakers, we shine a light on what it means to live and breathe better. This is Beyond the Wheeze. Today, I'm welcoming back Dr. Meraj Khan to the show. Dr. Khan first joined Beyond the Wheeze in episode 17 of season 1, where we explored his background as a clinical research scientist, his work at Sick Kids in Toronto, and the vision behind DigiBios, particularly how AI-driven platforms like LungSense could shape the future of respiratory care. Since that conversation, AI in healthcare has continued to accelerate, but alongside that momentum, important questions have surfaced, especially around real-world adoption, clinical trust, and whether these tools are truly ready to support people living with asthma. Dr. Khan is a clinical research scientist and health tech entrepreneur whose work sits at the intersection of AI, respiratory medicine, and clinical implementation. As co-founder and CEO of Digi Bios, his focus is not just on what AI can do, but on how it fits into real-world clinics, real workflows, and real patient care. Today's conversation builds directly on episode 17. This time, we're moving beyond the promise and asking a more grounded question. Is AI ready for real-world asthma care? With all that being said, Dr. Khan, welcome back to Beyond the Wheeze. Thank you so much for agreeing to come back on.
Thank you very much. It's my pleasure.
Since we last spoke, AI in healthcare has moved fast, but adoption often hasn't. From where you sit, what's the gap between what AI can do and what's actually happening in asthma care today?
I mean, that's a very good question because for me, I am kind of facing this challenge in real time. And the gap isn't really about technology anymore now. It's about translation into care. Our healthcare system, ecosystems, they're not worried about the technology. They're really about what value we are bringing. And as we know, AI can already predict exacerbation, monitor symptoms remotely, and even provide personalized care. But in practicality, even especially mostly in asthma care, the care still relies on episodic visits, manual tracking, maneuver, and that's the challenge. And if I can summarize all three, the key barriers, the barriers are that AI tools is not fitting smoothly into clinical workflow. There are so many tools, but the tools should be fit into the existing clinical workflow so that the clinician or healthcare providers, they don't feel overwhelmed. They don't feel, oh, this is something new they need to learn. Rather, they feel, okay, there's one add-on system. That tool or system is giving efficiency to their workflow. And because of that, they are much efficient in taking care of asthma care. There's one thing. The second thing is we have tools, we have technology, but there's no real world validation. In healthcare, the technology is not the problem. The problem is real world validation. And the third point, which is also important, our healthcare systems and reimbursement models are still lagging behind. So if I can summarize, the missing link is continuous real world monitoring and early risk detection. AI is powerful, we know that, but it's mostly sitting outside daily care workflow. Most of the technology or AI and the system is not in our workflow so that we can leverage it and we can understand the pain point of patients, pain point of due diligence, and pain point of our clinician. That is something which is needed now. So I kind of emphasize again, we need to think more the utility. We need to think how innovation can bring the impact. Not too much in innovation side that is needed too, but we need to focus on that. I can give one analogy. So we all, and most of the companies and institutions have R&D, right? Research and development. In R&D, what we do, we mostly do a research, but there's no development. And R&D is something when you do a research, you do a development, and also D is also deployment. R&D is not only the research and development, R&D is research, development, and deployment. So if we complete these three components, then we really bring a very valuable impact to our community, especially lung anomalies domain, even focusing asthma care.
When clinicians hear AI and asthma, many still think in terms of pilots or future tools. What applications are genuinely ready now, and which ones do you think are still being oversold?
I mean, so there are many components which are already achieved, but if we see, so there is a real concern in terms of clinicians are right to be cautious, right? Clinicians are they more worry about the patient safety and the outcome. They don't worry about how the technology is working. What are the numbers? What is the accuracy? What is the algorithm? They are really concerned and focused how can they manage their patient and then bring a good treatment. Managing patient is one thing, how early we can diagnose, because early diagnosis will really help to minimize the disease progression. That will also minimize patient suffering. That will minimize so many unnecessary things or delayed process. So that's the real value clinicians are looking. And in so currently what happened, there are AI tools which supports early screening, supports risk stratification. They also supports in decision making. Even they help in triaging. Like in our case, what we are building, we are trying to capture early symptoms of lung problem, whether it's asthma, COPD, or other. We are trying to capture their acoustics, symptoms, and kind of flag out something, and that helps the patient and even a clinician to have a better planning and to have a preventive care rather reactive care. The the near term value of AI in asthma is not about replacing clinicians. This is very important. We always talk about, or we always fear, oh, are we going to replace clinician? No, not at all. We are going to empower clinicians. We are going to empower our patient so that any patient who has a long uh, chronic asthma problem, he can manage himself. He do not have to be extremely dependent on our system, on our expert. That is the purpose of AI, not replacing anyone, rather empowering end user, patients, and even clinicians. And it is about giving them. So empowering means what? Empowering means we are giving them early signals, both ways. We are giving clinician better visibility between multiple visits, between symptoms, between treatment, and even after getting the treatment, how they are responding, whether the treatment is responding or not. So all these can be pretty much visible and managed and tracked by patient. So there is a huge empowerment we can provide by using AI, but using AI in a sense that we are not just using AI because of the AI. We are using AI for bringing a value, bringing a trust, and bringing adoption.
So let's talk a little bit now about what real world asthma care actually looks like. Many AI tools are built in controlled environments. What gets lost when those tools hit the realities of busy clinics, limited time, and complex patients?
That's actually a very important question. So now there is a race, right? In this era, the race of developing AI tools, AI platform, apps, and what missing is what we already most often we get the things lost is the context. The AI tool is there, technology is there, apps is there, but what is the context? What is the problem we are solving? That is actually missing. And I mean, it has a long discussion I can take, but that also brings when we going to adopt or we going to bring any AI technology in our healthcare system, especially in asthma care, we need to have our AI readiness framework. What it is, AI readiness framework is a kind of framework where we have three components. One is understanding the problem, PMO. P is for understanding the problem. M is for managing. How we manage to solve that problem. We understand the problem, how we manage to solve the problem. And then how we can operationalize it and how we can bring toward the real world scenario. So this is something is needed. And this is something which I say we lost the context in a summarized way. The second problem is when we develop the AI models or everything, we do in a controlled environment where data is clean, patients are stable, and workflows are predictable. But in a real world scenario or real clinic scenario, there's a huge complexity. Every patient is having their own physiology, their own symptoms, their own kind of context. Time is limited. Decisions are made under pressure. So you can clearly compare the difference between control or simulated environment with the real world clinical environment. So that's the gap we need to fill in AI. AI is good. AI is there in simulated or control environment, but we need to bring this to our clinical environment. Having said that, this simulated and controlled environment is good for some other purposes, non-healthcare. But in healthcare, we cannot use this. We cannot equalize the control environment or simulated environment with clinical real-world scenario. And this clinical real-world scenario is different in every places, every city to city, province to province, even country to country. The reason is why? Because of our ethnicity, because our geographical situation, because of our climate pattern. And all these impacts are related to directly or indirectly to our health system. So that's the challenge for all the innovators or founders to position in a way or think in a way so that you're not too much focused in technology, rather you are focused in bringing the impact. If it is done, then definitely adoption would be much easier and their consequences output would be much, much beneficial. And I will end this thing, what we adopted. So the real world adoption actually is depends on not the algorithm, not the numbers. That depends on the conditions, the impact, and how we are bringing the efficiency to empower patients, to empower clinicians, and to empower whole healthcare ecosystem.
And from your experience working with clinicians, what are the most common reasons AI tools fail to gain traction even when the underlying science is so strong?
Again, this answer I can bring back to my previous discussion. So the AI technology rarely fails because since it's weak or since there is a problem, since it's not have enough data. They fail because they don't fit into clinical reality. And that's what I emphasized in the previous discussion. We should have a strong AI readiness framework where we first understand the real challenge. And then we should bring an objective which are 100% aligned with our challenge. So there should be a real alignment. That's the main pointer, or we can say a quality control, or is a blocker when we bring AI to the real world healthcare system. It's not because of technology. There's no any kind of any problem in a seamless integration. The problem is the bringing to the real world scenario. And the second point is there's a lack of trust and transparency. So currently, when we use any AI tool, we don't know. It's kind of a simple AI tool, which is a black box, right? So we need to bring a trust and transparency, because when it matters to my health, I'm not going to trust anyone. I want to have my own explainability at my level, right? So we need to bring a trust and transparency. And this is something we can bring only when we will involve clinicians, when we can involve end users. That's the second pointer which I want to highlight, that is trust and transparency. The third is the many tools solve problems that aren't urgent for frontline care. And sometimes the strong science doesn't always translate into daily clinic value. What does it mean? We want to solve a problem that has a clinical value. It's not just something we want to solve a problem, but for the sake of solving the problem. Ultimately, long story short, adoption happens when AI reduces burden, supports decision making, and integrates naturally how care is already delivered. So this should be a kind of punchline, and this is the same punchline we follow when we are developing our products. So AI cannot be just simply built by data or by some algorithm and deploy. No, it needs to be supporting decision-making systems, and this should be naturally fitting into the real clinical workflow.
Now, I'd like to discuss lung sense a little bit, but before that, I have one more question for patients and caregivers listening. What should they realistically expect from AI-supported asthma care today, and what should raise healthy skepticism?
In this case, actually, the caregivers should expect AI to support care, not replace them. Right. So whether it's the PSW caregivers, healthcare practitioner, or anyone, they should be kind of having that much trust or that much reliability to know that, okay, this technology is going to support in terms of bringing efficiency, in terms of bringing the accuracy, in terms of bringing the automation, not replacing them. And this is something which is not even possible. We need to have a human intervention up to some point where we can see how the process is working, how the data intake is there, and after that, what is the output is coming. That's one. That's the second problem. Is it's not something you build an AI, you train your model, you integrate, and the process is simply running from data to all the way to outcome. So there are many components that also deteriorate the performance of AI. So we need to have a regular audit. We need to have a regular check. We need to have a regular QC so that we'll see how our AI is performing. The second, the challenge is that especially in the lung related problems, the data is changing. The data and the impact is also the climate or the seasonality. Let's say our AI model is built in a particular season, summer or winter or fall winter or a season where there's a huge allergens. It's not built by integrating the whole seasonality of the data, then definitely that will fall apart. So these are the key consideration we should consider, and that's why my focus is any tool which is going to be utilized, that should be tested, validated in a real world scenario, and based on the outcome that we can kind of evaluate and then bring to the hospital or the healthcare system, because that will help us to gain the trust and also align perfectly to the need of the healthcare system to treat asthma patient and even other disease modalities.
So using lung sense as a case study, as the example, what lessons have you learned about translating AI from development into real clinical use in respiratory care?
So, I mean, this is again a very good question. So when I transitioned from my benchside research to the bedside, and when I really started looking the impact in terms of the usefulness. So I want to bring another point here. So earlier my focus was to bring the impact in terms of perfection. So when I was doing research, innovations, optimizing the protocol and getting the output which is perfect. Now here the mindset is same, but the ideology is changed. I'm more focusing in terms of optimization and perfecting the usefulness. Like, so how my tool and up to what extent my tool is useful for patient care, useful for patient diagnosis, disease diagnosis, and even help to the clinicians. So this is the kind of background context. In terms of the learning, so when we developed lung sense, so we started with asthma, capturing early symptoms, capturing the monitoring to make sure we can also predict not only the problem, we can also predict the chances of having an episodic exacerbation, and that is a very critical. I want to actually pause this and then bring another real story. One of my friend I met, and he is a C-level executive officer in some other company in PNG. His son, actually, he himself and his son has asthma, long-term asthma, and he was telling me that his son has his trip with friends to somewhere in US, and he was in a province where the altitude is high, so he was hiking in mountain, and because of the pressure, we know that the pressure when you go to the mountain and higher altitude or latitude, the pressure drop. and he got a sudden exacerbation of asthma. He was not aware of that. And he told me that it was so hard to kind of manage. Like he's just said, "Oh, we just snatched him from the death." So those kind of situation can be managed. We we can predict the exacerbation or episodes of those kind of situations. So that was our focus. But now in lung sense, asthma is not the problem only. If I see the disease burden globally, the disease burden is because of asthma in lung domain, because of asthma, COPD, tuberculosis, lung cancer, and pneumonia. So our learning was to not just focus in one problem, rather to kind of expand it and bring something which can monitor your lung wellness, early screen lung anomalies that may lead to any chronic problem, and that will help us to kind of support the community. What we learned so far, we learned that AI must work with imperfect data, noisy environment, and diverse patients. Because if we build our AI, which is all with all the good data, good environment, simulated situation, then this is not gonna be this is not gonna be translated to the real world situation, because in a clinics there is a noisy environment. The patient is coming from different diversity or diverse background and so on. So that was our critical learning, to not to worry too much in building the AI model, multimodal approach, or whatever, or any advanced algorithm in a simulated situation, rather think in a real environment. And that's what we started implementing. We got a connections and collaboration with St. Joseph Hospital with the help of NRC IRAP, and we deployed our tool LungSense in St. Joseph Hospital. And our next milestones are to have some strategic partnership with long-term care, where we can also bring our tool and start capturing some data and show them the value proposition. We're not going to go to them and say, okay, hey, can you use our tool? No, because our approach is different. We want to take our tool platform and show the value out of it. Differently, then that will help us to scale up in many long-term clinics, remote clinic, and even we can bring to the home health version.
What feedback from clinicians or patients has most influenced how you've refined the platform thus far?
I mean, that's a very good pointer. And as I mentioned, so when we build our first proof of concept, that was a huge learning. And I can say that the learning was like exponential curve, huge learning curve. And finally, I learned in a hard way that no, this is not going to help us unless we will involve the healthcare practitioner, because they are the one who really understand the whole end-to-end problem. They understand, and they have experienced end-to-end journey. So we involved them, and what the feedback I get this quote in one line: the clinician expect, quote unquote, don't give us more data, give us clarity. And this is the point where we started bringing the explainability in our tool. Our platform is not just collect a bunch of data and give something. Oh, hey, you have a risk of this disease, or there is a chances of having asthma exacerbation in next 24 hours. No, we want to give the explainability. Whatever summary, whatever output is there, these are the factors, these are the pointers, and these are the supporting data. Based on that, our platform is kind of giving this output. This will bring trust. This will also bring the explainability, and even not only the trust to the end user, rather this will also bring a huge value to the decision maker, the clinicians. And that's a shift actually we got recently, and because of that, our traction actually got increased significantly.
So you spoke about trust, and I know on the last podcast episode we spoke about trust a little bit as well. So maybe a good segue into that. Trust comes up constantly in conversations about AI. I've heard it lots. I'm sure you've heard it lots as well. From a clinician's perspective, what does trustworthy AI, quote unquote, actually mean in asthma care?
And trust is not just something. It's not a bike ride or car ride. When I had a let's say when I'm going to buy a car, I just had a ride and then I say, oh, this is amazing. No, this is not. Trust, especially in healthcare, brings, it's a kind of journey too. It's not one time or second time. For example, when I'm using, I'm not just selling my component, my product. Rather, let's say I'm using a device or tool for my lung wellness tracker. So I know what kind of data has been there to train this model, this device, or build this device. And this again comes AI readiness framework or data governance. So I know the trust. I have a trust that this algorithm or this AI model has been trained by this much data. The training involved data governance means the data has taken all the precautions of data privacy, data biasness, data management, and ethical concern too. So that's one step of one level of trust to know. Okay, the model is trained. Their data has been processed by data governance. The second is what is the output of what is the performance of our model is coming along. Nowadays, most of us they understand the model. It's not AI is not just a buzzword. We all know, okay, AI means they must have gone through training their models by datasets. So we also need to know the performance of models. What is the accuracy? What is the false positive, false negative? In healthcare, this is a very important and a key aspect to understand whether if I'm getting to know about any outcome, whether it's asthma, COPD, or any other disease. What is the false positive or false negative rate? What is the recall value? What is the specificity? What is the sensitivity of that outcome? So all these bring a second level of trust. The third level of trust is when I'm using this, definitely this should be customized or personalized to me. The output is not generalized. I don't want to name the other tools where if you put something, they will give a generalized output. So our output is very customized to me. And in moving forward, I can go and when I can add more data there. So my information, the output is going to be more personalized. So these are the three levels of trust that bring the trust and utility. Along with that, in healthcare system, trust is not from only patient side. Trust should be also coming from the healthcare side, because most often we blindly accept whatever my clinician say me. Okay, whatever he prescribed me for the medication. So because we know that this clinician has already gone through the years and years of learning, training, and experience, that the trust I got. In the same way, in case of AI system, we need to have trust from clinical side too. And the clinical side trust we can only get unless and until we involve the clinician. So the collaboration is key here, and all these metrics which I just walked through and explained, that brings trust. And trust is not just one time engagement or one time I use my tool and I like it. Trust builds over the journey and in a period of time.
And what role should patients play in understanding or interacting with AI-driven insights about their asthma?
I mean, that role is actually differently. This question is also based on different user personas. Let's say the patient is using that technology. What is their level of understanding the disease? What is the level of understanding the technology? And what is his area or domain of work? And there are so many factors that's coming around. But for end user, I kind of recommend they should know the biasness. They should know what are the factors, what are the data sets, what are the data governance policy has been adopted to build this one. Because that will bring most of the explainability. If end user don't know how my model is trained and what are the data parameters, what are the data features, and what are the government data governance policy and AI readiness framework, I cannot understand anything. So there should be there should be a digital literacy in that aspect that will bring more adoption. So I can kind of expand this area. So, and it has been seen recently, a technology is there that actually is also implemented in a healthcare system, but their adoption is not moving forward. Why? Because there is no training, there is no learning, there is no any eagerness to understand and then start adopting. So that's why we also need to have a strong. We should actually do a kind of a strong focus in adoption part. And adoption is not only just training or giving a visibility. Adoption comes in two ways. One is we should build our tool, we should build our technology so that can be scalable. What does it mean? It means that, let's say, our lung sense is there, a tool is there that can be deployed or used by a patient who has an asthma problem, a patient who is in long-term care, a patient who is in retirement home, a patient maybe he's traveling and he all of a sudden he need to track his lung wellness. Maybe he started having some feeling that he may get episodic exacerbation, then he can quickly use it. So the accessibility is very key in that aspect. So this is what is I'm focusing in terms of scalability. The second part is the access. The end user should have access. There should not be limitation in terms of access remotely or anywhere and any point of time that can be accessed. And then the third point is there's a responsibility of end user to learn it, to adopt it, just not blindly use it and just put it aside. Rather use it, understand this, and try to understand how better way you can use it. So these three components brings the adaptability. If our manufacturer or the company or the organization who innovated or who built, they should think in terms of scaling. They should also think it should be bringing the easiness for end user, accessible to end user, and end user should need to understand the whole platform or technology, and all three components will bring the adoption and usability, and that is a role of end user. End user or patient should have that much curiosity to understand and learn in a way so that they can use more efficiently and get the best outcome of any technology.
So a good time to leave the standard disclaimer. This is not medical advice. This conversation is for education and awareness only. It does not replace medical advice, diagnosis, or treatment. Anyone living with asthma or other respiratory condition should follow guidance from their healthcare provider and use the information discussed here as a complement, not a substitute for professional medical care. So move on to section 6 now, which is, can AI actually prevent asthma attacks? I think that's the question a lot of people have, including myself. Question number 1 here is, one of the biggest problems of AI really is prevention. Based on what you've seen so far, how close are we able to reliably predict asthma exacerbations in everyday care?
To my best experience and real world understanding, we are very close. We are closer than many people think, but not all the way there yet. We are very close to that, but differently, there are many things to cover. Today, AI can definitely, our AI is already there to spot early warning sign, as I already mentioned. AI can detect the worsening of the patterns. AI can also flag out higher risk patient. But what we are still missing and we need to improve is consistency across the real life. Right? So AI is good in detecting or spotting the early signs, symptoms, disease exacerbations, and risk factor. All is good, but we need to have consistency across different sets, like different ages, different environment. As I mentioned, in different weather conditions. We also need to have work in terms of every human has a different, their own physiological threshold. So all these things should be integrated. So in that situation, the prediction would be very reliable. Now the prediction is in silos based on the data with what we fed. If we have considered all these situations, definitely the prediction would be much, much more reliable. And then the prevention becomes really only those patients are used. So and in that situation, the prevention will be much easier. So that's why our focus is to have a multimodal approach, and that multimodal approach is not just modality in different disease situation. Rather, we have to bring the modality in different persona level, ethnicity, geographical conditions, environmental conditions. All will differently bring the thing a state where everyone can start utilizing this technology. But we are very close, as I can summarize what we improved within last 5 years. That improvement and innovation is amazing. I see, I can forecast that within few years we can differently bring all these in real world scenario, and that will be a real maybe that will be a time where we can say now we are shifting the healthcare paradigm from reactive to preventive, and in that case we can minimize huge disease burden, suffering, and actually that will ease the is our whole healthcare ecosystem in terms of minimizing the burden.
Where does AI add the most value right now in asthma care? Is it diagnosis, monitoring, risk stratification, or clinical decision support?
Actually, AI adds the most value in definitely in monitoring and risk stratification currently, because these are the low hanging fruit. Continuous monitoring, and based on the continuous monitoring, we can flag out the risk factor and risk stratification. And in that case, if I can kind of categorize, the first one is that help catch changes earlier, right? If we are monitoring continuously and we are able to do a risk stratification, we can definitely catch any flag or any changes much earlier. We can reduce the surprises, because sometimes what happen, even I'm asymptomatic, but when I go to doctor for something else and I get surprised for something else, right? So that will also reduce surprises. That will also kind of support more timely intervention. So definitely this monitoring and this certification will early help us to early catch the problem, reduce the surprises, and minimize the gap between symptom to the treatment. And overall, all these three factors will help to have the right treatment and the right time and this will definitely prevent disease exacerbation and the kind of episodic attack like we had in asthma. So for that, I can just summarize in the bottom line that AI won't prevent asthma attack on its own, for sure. I mean, but we need to predict timely with the timely actions and preventive possible the tasks. So definitely AI is there. It's not going to work automatically for us. We need to use it for the right purpose, for the right time, and right care.
Not a supplement, but rather a complement for the right care, as you said.
Yeah.
So now we move into barriers that still need to be solved. How do data quality bias and health equity influence whether AI helps or harms people with asthma?
That actually, I kind of highlighted AI readiness framework, but I didn't give much on data quality. So the data part, whenever we talk about data, there are so many questions coming around. I can summarize all in one framework, and that is called a data governance. So data governance is actually, I can define is data governance is nothing big. It's just an orchestration of how we are moving from data capturing to clean data to train the model, right? And in this process, data capture to the data readiness for model, it has three things. One is the size. So we have to work about huge data size. Data, let's say if we are talking about the real time data capture and monitoring, then the data is huge, the volume is huge, the diversity is huge, and we have to manage all data sets. That's a huge task. Then the data process, how we clean this, how we make sure data is not biased, who has captured the data, what time point data has been captured, what is the patient profile is different, what is the age factor, what is the gender, and patient may have many secondary problems. So that component is again it's a big area. Because in healthcare, the problem is the complexity. So we have to deal one complexity about size or volume. The second is the processing, how we acquiring data, who is acquiring data, how we can make sure data is not biased. We cannot involve a human being to check the data is biased or not. We need to have a model which that can self flag out if there's any inconsistency or if there is any inlier outlier. So that part is huge. Now the third part is here the ethical or concern, because that part also help us to bring trust. So we need to make sure our data is highly aligned with our objectives, right? It's not something we're building a tool for asthma and we are capturing data of tuberculosis or something else. So data should be 100% aligned with our objectives. Who is the owner? Who is the responsible person for any questions or any issues or any ambiguity coming around? So all this comes in the data governance. So if our data governance is adopted, then definitely the output would be explainable and much trustworthy. And definitely in that case, we can remove the biasness, we can remove inconsistency, we can remove missing values. Everything can be considered and undertaken. So that is our philosophy, and this is a philosophy most of the big organizations are following. Now coming to asthma care, I mean that's a serious, because if we don't follow all these things, then what happened? The outcome won't be reliable. The outcome won't be perfectly personalized. The outcome may be general, not having any customized or impactful aspect of environment, personal situations, or even secondary problem. So that is our focus, and that's what even most of the big organizations, they are taking care of the data governance so that they can provide the reliable solutions. In a nutshell, for any responsible or explainable AI that is going to be built on, they should have a diverse data, I already mentioned. They have a continuous monitoring of the data, and then they should have a continuous monitoring for data biasness, for future data, the prospective data which are coming. So diversity, continuous monitoring for the future prospective data, continuous monitoring for biasness, and they have a clear commitment to equity. That is done. If we have all three components, it means we are following the data governance, and that helps for any AI tools, specifically who in case of asthma, and definitely that process will build us a tool that's not going to harm people with asthma. They will definitely support and bring more efficient care to asthma patient. If you are not following, then there would be I say there would be a danger.
Dr. Khan, I want to do a quick myth versus reality, which is a new segment I've added to season 2. I'm going to say a myth I hear often about AI and asthma care, and I want you to respond with the reality. I'll start with myth number 1. AI can already replace clinicians in managing asthma.
I think this is myth. It's not replacing at all. I don't believe, and we should not actually try to. First of all, there's no AI cannot replace clinician. The second thing, we should not try to. Why cannot replace a clinician? I can give an example, and actually, it's not an example; it's analogy. See, we have, thanks God, we have capabilities to walk. Right? We have 2 legs, and we are walking. There is an invention of bike. There's an invention of car. There's an invention of train. Even there's an invention of plane. Right? Every invention were adding a huge efficiency to what? To reach from place A or point A to point B, right? You agree. But any invention, whether it's a simple bike riding or plane travel, they all added efficiency at their level. They minimize the distance, and they provide so much ease, but no one has replaced our capability to walk. The same is here. We are bringing AI to provide an efficiency, to provide better care, to provide better treatment, to provide better early diagnosis, but never and not to replace human or clinician. So that is the intent, and that's what I focus in that way. So if we have this mindset, so we're not going to be scared. What happened currently in our ecosystem, when we talk about AI or when we talk about any bringing any tools and technology, everyone susceptible, oh no, there should be so many risks. I know there are risks for any new technology. There are risks and there are the value propositions. So let's first see the value proposition, and then based on that, you also calculate the risk factors. And the purpose of calculating risk factor is not to scare and not to go to the adopting technology. The purpose is to understand the risk factor, calculate the risk factor, and mitigate this. The same we have in case of the example and analogy I gave. There are risks in every technology. Even riding a bike, there are risks, car or plane, and so on. So the same notion I want to give here: AI cannot replace clinician, and it should not try to. Thank you.
Myth number 2, if an AI model performs well in a study, it's ready for clinics.
No, but it's a good start. So if any model which is very good, performing very good, that's a very good, fantastic start. But this is not ready for clinic. As I mentioned, because clinic is a real world scenario where there is a clinic, there's lots of noise, patient rush, many complexities, secondary problems, and there are along with the patient, there are many attendants. There's a huge chaos, right? So we cannot just say, okay, we build a model, then let's use it. We need to have a proper validations, clinical trials, and then differently we can bring to the real world scenario.
Myth number 3, more data automatically means better AI.
More data, no, it doesn't always better. Better data is better, but it's not just automatically translate, oh, we have a better AI. So, and there's another aspect here. Better data means what, right? Better data, it doesn't mean the data is very fit to what we are thinking, right? Based on our hypothesis, based on our objective. The better data is we have to think in terms of the real world scenario, right? So the data looks good, amazing, but you never know there's a biasness, or you never know that the data is from one geographical region. Let's say we collected the patient monitoring of asthma in Canada, and any data engineer or data scientist you give him, he will be happy and he will build a model, but he don't have clinical prospects. So he is not going to ask, oh, his data is global or is particular ethnicity or particular age or particular gender. So these are all the components which we need. So having better data is good or better, but not best. We need to have many more components to add, and that will add to give a better AI.
Myth number 4, AI predictions are objective and they're unbiased.
It's again, actually, this is very relevant to the previous. The predictions are objective or unbiased. It depends on the data, right? What kind of data we have ingested. And there's a saying, I think I said in the last episode, garbage in, garbage out. The same way, whatever you train your model, they will tell you they will give the output. But in the process of real world trial, or can say, or piloting, that's what this component is needed. When we put the data which is altogether new from different prospects, from different seasonality, from different area, that itself brings a huge understanding or learning to the model. And what I recommend, so let's say we have a model, we trained it and we deployed in a hospital, we should have a continuous kind of recurrence auditing, where our model will retrain to the batch data and kind of see what is the drift, means what is the performance and how the output are coming aligned. That is something which we need, and that will bring the output more unbiased, more ethical, and more reliable and trustworthy.
So now let's talk about what ready really means. In your view, Dr. Khan, what does it actually look like when AI is ready for real-world asthma care?
I mean, actually, so this is again a kind of analogy I can say. Let's just one step back. So there is a specialist clinician who has a 10, 20, 15, 30 years of experience in asthma care. But it doesn't mean they fix the asthma problem. They are enabler, right? They understand the problem, and based on the experience, they will give us a better solution or treatment, right? The same thing is here. AI is not a solution by itself. It's an enabler, right? The biggest, and that's how the enabler is. I just gave an analogy, so I do not need to explain too much. So, but in this case, the biggest improvements in asthma care come when AI is combined with clinical workflow, right? So my point is, again, back to the multimodal model approach. If we integrate our AI model or AI tool with clinical workflow, patient engagement, their education, that will really help to intervene the problem or the upcoming exacerbation episode. So coming back, maybe putting all in nutshell, if we have multimodal approach, multimodal data, we involve clinician to get workflow data, we involve patient to get their data, their engagement, their literacy, adoption, all combined in one tool, that will definitely bring scalability, adoption, and the output would be really, really impactful. And this will really give an efficiency in this treatment in asthma care, like we have efficiency from walking to the just flying.
So next, I'd like to move on to guest reflection and updates before we wrap up. Dr. Khan, what's next for your work at DigiBiomics, and what should clinicians, researchers, or innovators be paying attention to right now?
That's a very good question. So what next? So at DigiBiomics, actually, we are really about moving from validation to impact. We already built, we already validated. Now we are more thinking in terms of the impact. And with our tool, LungSense, which, as I mentioned, this LungSense is focusing in detecting early symptoms by subjective and objective data and bringing the preventive care. We are focused on expanding real-world deployments. So our next focus is we want to deploy this in long-term care, remote setting, and continuing to build the clinical and regulatory foundation. Because these two things are very important to bring this to the market. We need to have more clinical data so that we can say our tool is already well proven, and our tool has added this much value proposition to the long-term care clinics or retirement home. And based on that, this is our regulatory foundation, regulatory approval. These three things are very important before bringing it to the market, because we don't want to bring something and we don't gain or win the trust of end user, whether it's clinicians or patient. The second thing in terms of clinical prospects, clinicians, researchers, and innovators, the big thing to pay attention is right now isn't just a smart AI or it's just a usable AI. This is, again, I mentioned to them, for clinical prospects, whether it's clinicians, end user, or researcher, we don't want to just give, this is a smarter version of AI, smarter version of model. We want to give, this is a real usable AI, usable tool. And a tool that fix workflow, earn trust, and actually improve care day to day, improve asthma problem day to day. That's the one thing. The next part which you ask is the next phase of health AI. Our tool is won't be defined by the promises. We always do a lot of promise, but we want to bring the reality. This is our time. We already made so many promises, so many things, but our focus is 3 milestones to bring to the real world deployment, hospitals, clinics, remote clinics, get more data, get a regulatory foundation, regulatory approvals, and show the reality, not just the promise. And this is what the future we are building in DigiBiomics. And for that, we need support like your organizations, clinicians, and even our patients and end users.
That's great. And I will offer as much support as I can from the position that I'm currently in.
No, thank you.
And I just wanted to thank you again for coming on. So we'll move on now to our final question, which you've been asked before. Whether you have asthma or not, every breath we take is a gift, a reminder of our resilience, our drive to keep going, and our power to define our own limits. With a single breath, you have the potential to move mountains and change the world. So I'll leave you with this. If you only had one last breath, but with it the power to influence the world, what would your message be?
I really love this question. So it's a bit tough to answer, but I was like thinking how I can answer. But the past episode you asked, so I really love that. So I was prepared for this. So let's say I'm gonna have my last breath. So what I'll do, so if I have had one last breath to influence the world, I will use it to remind people of this thing, the one I'm quoting. I'm going to remind people that breathe for those who struggle to breathe. So my breath is not for me. My breath is for me, not for me, sorry, for those who are struggling to breathe. And never forget, progress isn't measured by how fast we move, but how many lives we lift along the way. So this is the second component. The first component is I'm alive because I know I have to support others. Or I'm breathing because this breath is not for me. This breath is to protect someone who is struggling to breathe. And in the progress, because we always talk about progress, because we measure our progress by something, by some measurable aspect. So what I measure progress is not just I move fast, I brought my tool from idea to the market. No, all is needed, but how many lives we can lift along in my journey. These are the two components I want to give. And this I want to support by another kind of quote that is kind of some spiritual aspect. I don't know which. So there's a saying, let's say if you are dying, it's the same question you mentioned, and you say you just having few breaths, are you dying? And in your hand, you have some seed. Just throw your seed. Why? Because then they will grow and become a tree or plant, and they will help the others. So the same question you asked, I really appreciate this question. So if you want, I want to again reiterate, if you have to breathe, if you see that this is your going to be last breath, so influence the others by saying that, breathe for those who struggle to breathe. And never forget, progress isn't measured by how fast we move, rather how many lives we lift along the way.
Thank you for listening to Beyond the Wheeze. I'm your host, Josh Rayom. If today's conversation resonated with you, follow the show and share it with someone who might find it helpful. Guest bios and resources from this episode are available at beyondthewheeze.ca, and additional resources can be found in the show notes. Follow us on LinkedIn, where recap blogs are posted every Friday following new episodes, which are released every second Tuesday. You can also follow me on Instagram at the Asthma Runner. Remember, live with it, not in it. This is Beyond the Wheeze.